Good morning, everyone, and thank you for joining us for the first of two briefings on the future of public health data and analytics at the Centers for Disease Control and Prevention. Today's briefing is presented by Data Elemental to Health campaign in partnership with the CDC. I'm Erin Morton, and I lead the Data Elemental to Health campaign, which was founded in 2019, before COVID, to advocate for dedicated funding to the CDC to modernize our public health data infrastructure. Today, we will hear from a key congressional champion and a panel of experts about the CDC's Data Modernization Initiative, or DMI. What is it? Why is it essential? How is it making a difference in public health? And perhaps most importantly, what resources are needed to make DMI a success? Before we begin, I want to remind everyone that our event is being recorded today. If you have friends and colleagues who weren't able to join us, we look forward to sharing the recording with them. And please think about your questions as our panelists make their remarks. We'll do our best to get to as many questions as possible during the Q&A. After the formal program, please stick around for an informal meet and greet with a few panelists in this Zoom room. Joining me today are 5 distinguished panelists. Dr. Angela Dunn, Executive Director of the Salt Lake County Health Department and President-elect of the Council of State and Territorial Epidemiologists. Dr. Megan Crumpler, Laboratory Director of the Orange County Public Health Laboratory and member of the Association of Public Health Laboratories. Shauna Webster, Executive Director of the National Association for Public Health Statistics and Information Systems. Dr. Dan Jernigan, Deputy Director for Public Health Science and Surveillance at the CDC, and Valerie Rogers, Director of Government Relations at HIMSS. Congress first dedicated funding to DMI in fiscal year 2020, with annual appropriations every year since. This essential funding would not have happened without the ongoing leadership and support from Chairwoman Rosa DeLauro. Before we go any further, I want to turn the floor over to her.
Hello, this is Congresswoman Rosa DeLauro, representing Connecticut's 3rd Congressional District. I want to thank the Council of State and Territorial Epidemiologists and their partners in the Data Elemental to Health campaign for hosting this Congressional Briefing Series. And I must welcome all the staff from the congressional offices gathered here today to better understand the purpose of the Data Modernization Initiative at the Centers for Disease Control and Prevention. It is a privilege to help kick off this series and to focus on the need for sustained investments in our nation's public health data infrastructure. I was so proud to champion the first dedicated funding for the Data Modernization Initiative in the federal spending bill for 2020 with $50 million at CDC. And I am proud that this funding has continued in annual spending bills, as well as COVID supplemental appropriations, including doubling funding to $100 million in the recently passed federal spending bill that President Biden signed into law last month. These investments in public health data modernization are already paying off. For example, more states are implementing electronic case reporting. This means that when you visit your doctor, a hospital, or other healthcare facility, the essential data is automatically sent to your state public health agency so they can capture that data in real time. Electronic case reporting reduces manual processes, improving data quality and saving time, which is critical to identify disease outbreaks early. While there is a lot of work to be done to scale up electronic case reporting, health departments are already getting fewer faxes and dealing with less manual paper entry of patient information. Electronic case reporting is just one component of this critical effort. The COVID-19 pandemic has highlighted the need to make investments that support more dynamic public health data efforts. So let us learn from this pandemic and move forward together swiftly, stronger, and better than ever. I'm so proud to be your ally, and I'm excited about our future, working together and continuing our partnership for years to come.
Thank you, Chair DeLauro, for those inspiring remarks and for your tireless efforts in helping public health move away from the fax machine. As our panelists discuss the DMI today, you'll hear about 5 key pillars of public health data modernization, including electronic case reporting, or ECR, that Chair DeLauro spoke about. The other 4 pillars of data modernization are lab information management systems, including electronic laboratory ordering, or ELR, syndromic surveillance, the collection of real-time data from hospital emergency departments, electronic vital record systems that collect birth and death data from hospitals, funeral homes, healthcare providers, and medical examiners. And finally, the National Notifiable Disease Surveillance System, or NNDSS, the national system that collects, aggregates, and analyzes data from state and local public health agencies. Addressing each of these pillars is core to how DMI will modernize our public health data infrastructure. They have discrete needs, and each pillar must be funded according to those needs. To talk more about this now, please welcome Dr. Angela Dunn.
Thank you, and good morning, everyone. I really appreciate everyone being in our audience today to join us to discuss this important topic. I am Angela Dunn. I'm the Executive Director and Health Officer of the Salt Lake County Health Department and President-elect of the Council of State and Territorial Epidemiologists, or CSTE. CSTE represents public health epidemiologists nationwide, working in public health agencies to track diseases, monitor emerging threats, and our members have been on the front lines of the COVID response for the past 2 years. CSTE partners with the data, CSTE and our partners with the Data Elemental to Health campaign came together several years ago. This was before the COVID-19 pandemic. And we came together to make the case for investing in our long neglected public health infrastructure. While we were in the initial stages of our advocacy, the global pandemic, unlike any other we have seen in our lifetimes, struck. For COVID-19 and beyond, it is critical that we transform our existing public health data infrastructure from an outdated and burdensome system to a 21st century public health data superhighway, interoperable with healthcare that provides accurate, instantaneous data to state and local officials on the ground. We desperately need this. Aaron mentioned the 5 key pillars across public health data infrastructure, and they're all in need of sustained long-term federal investment. Coupled with the support for local and state level workforce and management, modernizing these 5 pillars will definitely go a long way to bring our public health data infrastructure into the modern age. The Data Elemental to Health campaign prepared a detailed cost estimate describing the resources needed for each of these pillars over the next 5 years. And I'm going to walk us through each one of those estimates. And you'll also be able to find the details of this estimate in the 2-pager, and it's going to be linked in the chat. Next slide. So the first pillar is electronic case reporting. This is an automatic, seamless submission of disease reports directly from electronic health records to, or that are at a clinical care organization, to our state and local, tribal, and territorial health departments. Hiring epidemiologists and building systems to manage ECR requires at least $656 million over 5 years, of which $336 million are human costs and $320 million are for systems. So ECR can help us identify populations at greatest risk for severe disease. So for example, at the height of the COVID pandemic in Utah, Hispanic communities made up over 50% of our COVID cases, despite only making up 15% of our population. And our Native Hawaiian Pacific Islander communities were more than twice as likely to be hospitalized or die from COVID than their white counterparts. And ECR allows us to understand these risk factors quickly so that public health officials on the ground can intervene to mitigate these burdens. I'll give another example. This is a room in my own health department. We definitely still have room for improvement in terms of becoming electronic. And the case I'm about to present to you is not abnormal. A lot of my colleagues across the nation are in the same boat. This is a picture. It's a secure storage room. Here you see 100 boxes, each with about 50 files for a total of 5,000 records. Several years ago, though, before you panic, this room would have been more than twice as filled because we relied more heavily on paper and faxes. However, the early stages of DMI has helped us transition some of our hospitals to electronic case reporting, lessening the amount of paper reporting. But we still have room for improvement. So in each one of these folders, There is a handwritten CDC case report that's filled out by one of our case investigators, and that data is entered into our electronic health system, and then the handwritten form is scanned. There's also hospitalization records. That's printed off from the electronic health record and then scanned into the public health surveillance system. So why are we still doing this if we have ECR? Well, not all of our hospitals are currently capable of ECR. We need more information for some of our high consequence pathogens than our current ECR systems are capable of. An investment in both the technology side and the workforce will help us transition the room full of boxes to having no boxes in there and having us be completely electronic with instantaneous information. Next slide. Perfect, thank you. So the next pillar is the lab information management system, and my colleague Megan is going to talk more about this next, but I'll cover the cost real quick. So putting LIMS, electronic laboratory reporting, and electronic test to order systems in place requires $1.032 billion over the next 5 years, of which $392 million is human costs and $640 million are for the systems. And this is going to provide lab systems lab results automatically to public health, alerting us to diseases of concern so that we can respond quickly. We're not going to be waiting for a fax or a call from a clinician. And this is essential to responding to emergent threats. Next slide. Syndromic surveillance, it provides near real-time data on hospital emergency data visits. This is a key cornerstone of public health surveillance, and implementing syndromic surveillance is going to require $310.4 million over the next 5 years. Again, $86.4 million are going to be human costs, and $224 million are for systems. And this syndromic surveillance has become very applicable in our recent COVID response. As more individuals are using home testing, which is a fantastic thing for COVID, syndromic surveillance is providing us testing independent metric of COVID transmission. So we also use syndromic surveillance every flu season to help hospitals prepare their staffing, bed allocation, medical supplies, and treatments. So it's an incredibly useful tool, but it is only as useful as the data that goes into it. And we need all hospitals and emergency rooms to be on board. And again, that takes resources. So funding and workforce dedicated to these connections is essential to allowing us to have a successful syndromic surveillance piece. Next. Electronic vital records. Again, my colleague Shawna is going to talk more about this and their role in DMI, but to ensure vital records modernization is included, we estimate that modernizing vital record systems is going to require $688 million over the next 5 years, of which $336 million are human costs and $352 million are for systems. And electronic vital records is crucial to public health. This is how we really learn about disease severity. Who is at highest risk for dying from COVID, for example? And the answer to this, it has impacted our policies and will continue to do so. Everything from social distancing to mask wearing to visitation policies at our long-term care facilities. These policies impact the lives and livelihoods, and they need to be backed by the most accurate and timely data. Our residents deserve this. Next. And last, the last pillar is the National Notifiable Disease Surveillance System. This collects individual case investigation data at state, local, tribal, and territorial public health agencies, and then shares that data directly with the CDC so that we can understand the disease burden at a national level. Bringing NNDSS into the 21st century is going to require about $1.24 billion over the next 5 years, of which $280 million are going to be human costs and $960 million are for systems. Modernizing NNDSS is going to bring efficiencies to the state public health systems. In Utah, we collect a robust amount of data on all of our reportable conditions. We're very fortunate to have investment and great capacity here in that regard. And this directly informs our mitigation measures. So I'll actually give you a non-COVID example. So before COVID, actually right before COVID, we had EVALI. That was the lung disease that was caused by vaping. And in Utah, we received hospitalization data directly from our healthcare partners, and it went into our surveillance system. This allowed us to quickly identify the demographics of the people at highest risk so that we could develop targeted interventions to protect their health. In this case, it was young adults and teens who vaped. And because we had that connection with our healthcare systems, we were able to identify which communities had the highest burden and work directly with those tobacco specialty shops to alert the at-risk population. However, even though we had all of this important data streamlined at the state, we had to send multiple data sets to the CDC because their systems didn't have the ability to accept all of our data in one streamlined data stream. And this happened across the country, resulting in delayed national understanding of the problem. So modernizing NNDSSS will help solve that and help us get that national picture more quickly. Next. And of course, building data infrastructure and having this great superhighway is crucial, but we also need a workforce to be able to use that data. The state and local workforce is a critical component of this. We have seen a lot of burnout among our public health workforce, and we need to really invest in well-trained, sustainable public health workforce that's prepared to respond to any emerging public health threat. They need to be able to bring in this timely data, analyze it, interpret it, and then apply the information to effective interventions. Next slide. And lastly, I want to emphasize that this is the minimum investment necessary to bring our antiquated public health data system into the 21st century. That minimum necessary is $7.84 billion over 5 years in CDC's Data Modernization Initiative at the state and local levels. We can't continue to manage public health on this crisis to crisis basis. We really need sustained, reliable, long-term investment to ensure our system will be working when the next public health threat hits. So we're asking Congress to dedicate at least $1.57 billion per year to fully modernize our public health data infrastructure at the state and local levels. We are grateful for the funding that's been appropriated to CDC's Data Modernization Initiative so far, and we're asking Congress to allocate at least $250 million for fiscal year 2023. This is an important investment, but we must understand that it's not enough to create the system that we need to be successful and healthy in the future. Thank you. Oh, and sorry, Erin, I would like to turn it over to my colleague, Megan. Thanks, Megan.
Good morning, and thank you for the privilege to speak with you today. My name is Megan Crumpler, and I currently serve as the laboratory director for both Orange County and Long Beach City Public Health Laboratories, both located in Southern California. I am also a local institutional representative on the Association of Public Health Laboratories Board of Directors, and today I am here representing APHL. APHL is an organization that represents state and local governmental health laboratories in the United States. Its members, known as public health laboratories, monitor, detect, and respond to health threats. Today, we are talking about data, and the data that public health laboratories generate is the cornerstone of surveillance. Our laboratories provide testing for foodborne outbreaks, newborn screening, influenza surveillance, and of course, COVID-19. Public health laboratories are data rich, but our surveillance systems are information poor because we do not have the people or systems to extrapolate and transmit the data well. There are many misconceptions about how laboratory data is currently transmitted. In our personal lives, we carry many computers in our pockets with any information we want at our fingertips. Yet many laboratories, similar to Angela's stories and her photos of boxes and boxes of paper, still manually enter data from paper test request forms into laboratory information management systems and send results by fax, email, or even traditional mail. As Erin and Angela reviewed, the Data Elemental to Health campaign names laboratory information systems, or LIMS, as one of the 5 pillars of the data modernization initiative that require investment. LIMS are the backbone for laboratory data analysis, management, and sharing, while electronic test order and result, or ETOR interfaces, enable laboratories to electronically transfer this data. In short, ETOR is the bidirectional capability to transmit and receive clinical, environmental, agricultural, or animal specimen test order and result data between 2 parties electronically. For example, a provider orders a lab test in the electronic medical record, or EMR. Next, the test order and patient information are sent to the testing lab by ETOR interface. The lab performs the test and the result is sent back to the EMR using a LIMS ETOR interface. That result is now part of the patient record, but the data does not stop there. For reportable diseases such as salmonella, tuberculosis, and rabies, the laboratory will electronically report by ELR to a local, state, or national electronic disease reporting and surveillance system. ETOR has had limited focus and attention, but it is integral to the modernization of our public health system. Across public health labs, there is a variable ETOR capability, often with a limited number of tests or providers. For example, in my laboratory, we have ETOR set up with 2 clients, our county clinics and correctional health, but we still receive paper test requests from all other submitters. ETOR improves the timeliness and quality of data, can increase health equity, reduces manual entry, and lowers the barriers to entry for integration of emerging technologies. It also allows results to be viewed in near real time, improving patient care by ensuring that swift action can be taken if needed for early intervention. ETOR is essential for public health laboratories to function effectively. Improving the public health ETOR infrastructure within state and local laboratories will not only augment patient management in the laboratory's workflows, but will also expedite and strengthen broader public health surveillance and response efforts. Federal funding sent to public health labs throughout the COVID-19 pandemic has accelerated adoption and initiation of ETOR projects. Many of these were just future wish list items for laboratories when there was money in the budget to complete them. Here are some examples. The APHL AIMS platform, which started with influenza data transfer, has gone from a hidden secret to playing a central role for data exchange, acting as the data sharing solution for COVID, and sends data to the White House and HHS Protect program. Iowa State Public Health Lab used federal ELC funding to acquire a data innovations instrument manager to build connectivity between the LIMS and COVID testing instruments that performed 1.75 million COVID tests. Iowa also implemented ETOR and estimate a time savings of more than 21,000 staff hours saved since they went live in mid-2020. Wyoming implemented ETOR and also hired a LIMS administrator and bioinformatician. They shared that they would have never been able to accomplish these goals without this important funding. For every example shared, imagine that this or something very similar is happening across 126 public health laboratories. We cannot accomplish our DMI dreams without ongoing financial support in the years ahead. Most current federal funding needs to be spent in the next 1 to 2 years, which are not practical deadlines for these complex projects. Finally, and maybe most importantly, we cannot do the work without the people. In an APHL survey of 46 member laboratories, more than 85% of public health labs stated that they do not have the workforce needed to implement critical informatics initiatives. These skill sets are not typically part of a traditional laboratorian's training, and yet we need to incorporate these positions in the laboratory personnel staffing model. Specialized workforce development training programs are essential to the success of DMI. In closing, core public health surveillance is dependent on quality laboratory results that are transmitted to local, state, and national public health authorities in a timely manner. Personally, I have been amazed at what our laboratory and others have been able to do with COVID funding, and I hope that you see what is achievable if we receive long-term sustained funding. The possibilities are truly endless. Thank you for your time today, and next you will hear from Shauna Webster.
Thanks so much, Megan. Good morning. I'm Shauna Webster, Executive Director of NAFSIS, representing the nation's 57 vital records jurisdictions. It's a pleasure to have you all with us this morning. Vital records are the very bedrock of all public health reporting and the origin of individual identity in this nation. As such, it is a core pillar of the Data Modernization Initiative and a key component of the cost estimates that Angela outlined earlier. Collection of vital records, including information about births, deaths, marriages, adoptions, citizenships, and other life events, is the legal responsibility of the states, not the federal government. While vital records and their data are thus collected and owned by the states, and access to records is heavily regulated by individual state law. Over the past 20 years, vital records has transitioned from an entirely paper-based process to one that relies on complex electronic systems to collect, exchange, and deliver vital records data to federal and state public health entities like the National Center for Health Statistics and other parts of CDC, including some of the other systems we've just talked about. The transformation in vital records registration systems over the past 2 decades has been a tremendous step forward and has increased timeliness by leaps and bounds. Thanks to these advances supported by our colleagues at CDC, the National Vital Record System was able to provide reliable mortality data for both local and national reporting during the pandemic. But we have a really long way to go to achieve a modern vital records infrastructure that supports interoperability and real-time surveillance. Most vital records agency systems are 5 to 10 years old and built on out-of-date technology. This technology deficit means that states are spending what little money they have on fixing and maintaining these legacy systems because they can't afford the upfront cost of a new system. To purchase and implement a new modern vital records agency system, it could cost a state anywhere from 5 to 10 million. And we're not talking about just one system per jurisdiction. In most jurisdictions, they manage at least 2, at least one for birth and one for death registration. Multiply this by 57, and you'll understand the technology component of the cost estimates Angela outlined. And that's just systems. The annual cost associated with the entire vital records agencies nationwide is about $300 million. Based on how many people are born and die in each state every year, we can find the average cost of an individual vital record, which is about $150. Right now, CDC and SSA, who are the 2 primary consumers of vital records data at the federal level, pay about $3 a piece for each file. Who pays the other $144? You do, we do. The average American pays the balance for the right to use their own identity. These numbers are based on current operating capacity on aging systems with no interoperability. The true cost of upgrading and maintaining this core pillar is nearly $700 million over 5 years. Last year, the CDC invested $77 million of supplemental funding into vital records across the 57 jurisdictions. While this is an important first step and states are working quickly to use that money for small system developments and enhancements, it doesn't get us to what is truly needed for states to make the necessary improvements for the long term. States cannot, will not spend one-time money on new staff or new systems that they know they can't support or pay for after the current crisis funding has dried up. One-time funding is frankly what got us where we are today. No one would buy a phone or computer now and expect it to last a decade, let alone 2. Technology and the skilled workforce needed to maintain it is an ongoing investment. We cannot be expected to operate crisis to crisis anymore, and public health should not be the poster child for the scrappy state government agency who does more with less. Vital records itself is far too important to be so dramatically undervalued. And is needed to modernize our vital records system and maintain them over time. And the federal government relies heavily on vital records data, whether it's for public health purposes that we're talking about today or for fraud prevention. And the states should be reimbursed at a much higher rate to support these essential services. That way, our state agencies won't be living crisis to crisis just to keep the lights on. This is how we achieve data modernization for vital records. And that's why it's so important to support these initiatives now. Thank you so much for having us here today. And with that, I'll turn it over to my colleague, Dan, with CDC.
Great, thanks very much. And so thanks very much for the opportunity to speak with you, and also just to say thanks so much to the folks that have been putting the data elemental to health work together, the vision that they had prior to the pandemic, and the continued support for it going forward. It has been a transformative activity at CDC to receive funding for that. If you could go to the next slide. So at CDC, with the resources that we have been able to receive, we have taken all of the information that we've gathered from a lot of different places, including data elemental to health, and put that into a set of priorities. And those priorities are available at our CDC website if you'd like to look at them and see what we're planning to do over the next several years. Our ultimate goal here is to move from siloed and brittle public health data systems to connected, resilient, adaptable, and sustainable response-ready systems that can help us solve problems before they happen and reduce the harm caused by the problems that do happen. So essentially, we are looking for better, faster, actionable intelligence for decision-making at all levels of public health. And data elemental to health is absolutely critical for us to be able to do that activity. If you could go to the next slide. So what are we doing? If you go to our CDC DMI website, you can actually see our 2021 accomplishments PDF that's available there, and other information that can give you more about the details of what has happened. But at the federal level, we're unifying our data at CDC and supporting policies that make data sharing easier. We're building a new cloud environment. So as Angela mentioned earlier, they had data, they wanted to give it to us. We couldn't receive it in an efficient way. We're making those changes to be able to receive that NNDSS information. We're also providing ways to break down software silos that different programs have so that we don't have to iterate those silos at each state health department, so that we have common ways of doing things. And then we're also looking at and implementing new approaches for using the same platform for different surveillance systems. So for instance, now with the new wastewater system, it's using the same platform as we're doing for Legionnaire's disease, the same one we're using for foodborne, which is the same one we're using for COVID. So collapsing these things, harmonizing things, and making things more efficient and sustainable. At the state and local level, we're building up our public health workforce and strengthening connections for timelier, more accurate data. I think Angela's picture of those papers, I think, tells most of the story there of what needs to happen. Places like Dallas County, where Dr. Philip Wong has actually transformed what he's doing by having data come in from these automated data sources, being able to integrate that information and get data and interpretations much faster so that he can make decisions about Dallas County quickly. And then for the public, we're supporting equitable health and providing more real-time data for decisions. We have open data that's available for researchers and for the public to use now. Our COVID data tracker website is up. It gives lots of information. And then finally, by doing these automated electronic capture of information that are outlined as the priorities for the data elemental to health, we are able to increase the amount of race ethnicity data that's coming through that automated reporting so that we can see which communities are impacted disproportionately because of COVID and going forward for other emerging threats. If you could go to the next slide, just to look at some of the accomplishments that have happened because of COVID, because of DMI, because of data elemental to health. We have now over 813 million COVID-19 test reports that have come through electronically, something that just would have never been thought of prior to these efforts. Case-based disease surveillance of 79 million case reports, especially the electronic case reporting that is now in place with just over the last several months, up to 11,000 providers. That means less faxes. That means doctors doing doctor stuff rather than having to fill out pieces of paper. 7.4 emergency department visits as a part of that syndromic surveillance system, not just COVID, but we are also able to see all kinds of encounters and pick up trends that we would not have been able to see for not only infectious diseases, but non-infectious diseases as well. 551 immunization records, 2.1 virus genomes, healthcare data, 140 terabytes of data that we have at CDC, so that we do not have to start a new surveillance system. We simply go to those healthcare records that are already available, they are de-identified, and we can find things like multi-system inflammatory syndrome in children, what's happening in that space. So using data differently. And then finally, about 4.6 million hospitalization reports coming through that help us to know whether you're low, medium, or high with regard to your risks for COVID at this time. Next slide. So from our, as was mentioned previously by Angela, the base now 100 million in FY22, that is incredibly helpful, but is not at the level that would be needed going forward without the supplementals. The supplementals we've received so far, 500 million of CARES Act, 500 million of American Rescue Plan, where 300 of that goes toward the data modernization initiatives, specifically like the foundational efforts, and 200 million go to the new Center for Forecasting and Outbreak Analytics. That's a critical new feature that was just launched yesterday or 2 days ago from the White House meeting, indicating how that center will be moving forward as an interagency and public health utility for forecasting. But it's only as good as the data that can get in there, and the DMI efforts are what's making that data available so that we can do better local, state, and national forecasting. There are a number of investments that are listed there. We'll be providing the slides to you. Funding for states and locals to build foundational data capabilities. It was mentioned how we are supporting DMI non-specific efforts, getting people to do their strategies, figure out what they need, but also the support for electronic case reporting, and also for the vitals that Shauna mentioned previously. A number of other things happening there, especially this North Star architecture, which is being developed in coordination with the Office of the National Coordinator, Mickey Tripathi, at HHS, so that we're aligning what's happening in the healthcare system with what's happening in the public health system, so that their public health can begin talking with the healthcare systems, just like a pharmacy talks to a hospital. We need to be able to get to that kind of connectivity so that we can realize the gains of the data elemental to health activities. Next slide. So when all of this is together, what does it mean? What will success look like? With these efforts that have been started, that are underway, and that need to have continued support so that we can achieve them, we would decrease burden on doctors and hospitals by replacing faxes and phone calls with automated reporting directly from electronic health records. We would free up public health staff by providing them the infrastructure, the tools, and the training to use data for more targeted interventions for their communities. That is, make the data work for state and local partners rather than them just trying to work to get the data. And finally, to have awareness of emerging threats across the US at a national level to inform forecasting and to direct resources to prevent or mitigate public health impacts. And so with that, let me hand this over to Valerie Rogers, the Director of Government Relations at HIMSS.
Thank you, Dr. Jernigan. Again, Valerie Rogers here, Director of Government Relations at HIMSS. And we have certainly commend and support modernization efforts to date. However, we recognize that we have miles to go before we sleep. And if we go to the next slide, in order to calculate a baseline of investments, which builds upon some of the strategic goals that have been set forth by the CDC, DMI, by the Data Elemental to Health campaign members, and HIMSS itself, we recognize through our COVID-19 global policy call to action and emphasize in our current funding report that emphasizes both the public policy and business processes that must also transform in order to electronically transmit bidirectional reports to public health agencies, healthcare facilities, and health data exchanges in the United States really demands a more meaningful use approach to modernization. And that's inclusive of digitization, which we've talked about, moving from a paper-based infrastructure and leveraging, as the CDC has started to formulate, more cloud-based services. Standardization, which also is inclusive of supporting greater interoperability, meaning the ability to exchange information bidirectionally across the spectrum of care. And that's inclusive of behavioral health. Dr. Jernigan mentioned environmental health. There are a number of key services across the spectrum that must also be interoperated, meaning connected and able to talk to each other, to exchange and share information during a crisis or ongoing, and ongoing efforts are mundane efforts. And then also innovation to support the transformation of state, territorial, local, and tribal governmental health agencies to participate in a meaningful way. So in a sense, expanding our meaningful use to address our preparedness and our health equity issues that have really rose to the top of the challenges that we face in our combating the COVID-19 pandemic. But looking ahead, we realize that these state, territorial, local, and tribal agencies, or I'll call them STILTs to shorten it, they must be equipped to analyze and share electronically transmissible and visualized data and insights. So moving beyond just the digitization and the standardization, we must be able to use this data, as was so eloquently pointed out, I think, and multiple presenters have pointed to today. And, you know, this is really key during a pandemic response, as I've mentioned, but it also impacts digital literacy. It impacts our ability to expand access to care via telehealth or remote patient monitoring, which we saw a good deal of success during the pandemic. These are also not fundamentally what we think of when we think of public health, but public health definitely has a role, because all of these areas certainly address and attend to some of the health equity needs and concerns, such as maternal mortality surveillance and overarching disease reporting and digital patient engagement, all of which must be considered beyond just the acute response to a pandemic. And if we go to the next slide, we've talked about essential services, and those essential services, of course, must be prioritized for modernization. We are urging prioritization and additional support within a 5-year period, meaning we'd like to see, of course, our syndromic surveillance, all of our surveillance, our vital records reporting, our ELR, and so forth, really given the funding and attention, you know, in an immediate manner in order to prevent and be able to respond to ongoing health threats. I would say one of the issues that HIMSS has also addressed here and considered in our overall approach to what it would mean to modernize is that immunization registry reporting and query, which is another really key component to our ability to respond and ensure the health and safety of our populations, must also be included. We've also thought through the need for IT innovations, and you've heard about workforce capacity, building that workforce capacity, which must also work hand in hand with through the use of or expansion of innovations and care delivery. And then to create a trusted and secure access to multimodal health data. Again, reiterating the points made earlier about connecting to behavioral health, environmental health, and other systems in a secure manner. One of the key topics that HIMSS has addressed in our modernization funding report, which I have included in the chat function here, is a really concerted effort to ensure the safety and the privacy, addressing those privacy concerns. And so overarching investment for over a 5-year period, we're looking at $25.6 billion. Now, if we go on to the next slide, you see here within that 5-year period, we're also looking long-term. So how do we sustain these resources? How do we maintain these services? And so we are also proposing a 10-year investment, which is inclusive of the first 5-year investment, for a total investment of $36.7 billion to modernize our state, territorial, local, and tribal governmental public health data systems, our infrastructure, and to create a more interoperable and meaningful use exchange of these systems, more integrated and coordinated with our overarching healthcare system. And if we go to the next slide, you'll see here sort of a breakout of what that extended sustainability would mean. It would mean a little over $11 billion investment that again supports those essential services and functions that were mentioned earlier, but also take into account some of the interoperability and the privacy and security needs that were also addressed. And if we move to the next slide, we are also recommending that by 2030, as we move toward this more digital, integrated, interoperable health system, inclusive of public health and its partners, that we really focus on the multimodal health data across virtual, remote, and in-person services. Again, recognizing the need to support more cloud-based services, but also recognizing the need that those must be secure. This will take a large investment, a large amount of investment. We are estimating at least a $2 billion investment to ensure privacy, safety, and security. And this also goes to creating what those in the health informatics field have been working toward for many years now, and that is a nimble, rapid cycle learning health system environment. So what does that all mean? It means that we're able to galvanize the analytics, our strategic coordination across the spectrum of care, all of the reporting and care coordination that is necessary. One, not only to adapt to and address any emerging health threats that we may face, but to also think about our long-term strategy for digitization and to sustain that, those resources and that movement to ensure that we're a system working together, not in silos. And, finally, I would just say, reiterating again, the need for these systems, not only in terms of modernization for itself, but in terms of addressing some of our long-term outcomes as identified in Healthy People 2030, which addresses health inequities and disparities very robustly, I must say, including sustained transformation and modernization of our public health system ensures that we get there quickly and that we are able to address those goals that we have set for ourselves as a nation. And if we go on to the next slide here, just wrapping it up and looking ahead, we want to impress upon you that $36.7 billion seems like a lot, but I would remind us that, during meaningful use, we had a ton of investment in the healthcare industry, but we did not adequately fund and support and sustain state, local, territorial, tribal, governmental public health to the degree that we should have. This is our opportunity to do that, thinking through a 10-year process where we will be able to really support those health systems that collect and report. If we don't, we lose any value that we've gained through understanding the lessons learned from our COVID-19 response. And more so, I would also mention that the health IT and informatics community is also being really pushed to rethink their approach to public health, the data governance and standards, reforming sort of the web of some of the privacy and security issues is certainly supported in this funding recommendation. And if we go to the next slide, we'd just like to emphasize that it's really essential that we address these issues so that we have an aligned efforts at all across the spectrum at all levels of government, where we are able to move forward and adapt to and address those emerging threats that we may face down the road. Moreover, I would just like to emphasize, while we talk quite a bit about the acute, we've also included the need to include at least some evaluation and interoperability for the over 25 plus chronic disease surveillance data systems, which also support our overarching efforts to ensure a more comprehensive approach to a value-based whole person care and population health initiatives that have also been set forward by our Healthy People 2030, by the CDC DMI, and by really the demand that our citizens have as they consider how the U.S. public health system continues to support and uphold their overall health and well-being. So all of these funding considerations, if we just wrap up in this next slide here, are a $36.7 billion investment. It's really quite thorough. We tried to think through all of the connection points and hopefully left no stone unturned in terms of what it would actually take over a 10-year period to modernize. So thank you for your time.
Thanks, Valerie, and thanks everyone for those really great comments and remarks. I think that was a comprehensive overview of DMI, and I think lots of good information shared across the panelists. We don't have a lot of time in our regular hour left for Q&A, but as a reminder, we are going to have an informal session after this if you're able to stick around. But maybe before we do that, I'll just do a couple of real quick questions and folks can answer them as quickly as possible. But Dan, I want to go back to you because you talked a lot about what's happening with DMI and what CDC has already been doing. But can you give us a quick sense of kind of what's next for DMI at CDC, what you all have planned in the immediate term?
Yeah, no, that's great. And so I think, can also direct folks to the website that goes through a lot of those activities. But, we've identified 5 priorities at CDC, where 3 of them are really critical components. The first is to build the foundation. And so over the next year and the next couple of years, really looking to expand the use of cloud at CDC, develop enterprise-wide data analysis and visualization tools that everyone will need to use so they're not using their individual systems. And that means that it's a whole lot more interoperable to work with states for the data they're collecting and for the data that we are receiving from them. That foundation includes also doing that connections. And so ECR, we're going to see that continue to increase as long as there are funds to help support that. We think that's going to be a great thing because we can expand beyond COVID. We're already expanding in some states to include other communicable diseases that are reportable. And so over 108 different diseases that we will be able to get through that process. So we clearly want to move forward with that, with vital statistics, expanding the syndromic surveillance components as well. In our second priority is accelerating data to action. And that's really developing those systems for common operating pictures. That means just a common way that states, us, our local partners, when we're doing investigations, when we're doing big responses, we have a common way of having a repository of information so that we can share that data. And also to take the data we have and do things completely different with it. Forecasting more of the capabilities for scenario modeling, trying to layer additional information so that communities and local health departments can not only have their health information that they get about their reportable cases, but also the other information about the community so that we can learn more about it and understand the needs of the community and target public health and preventive services to those communities that are really requiring that additional support. All of that is, a lot to do, but it's only really if those resources are available there. And so we will be continuing to move forward in bringing the public health community into that healthcare ecosystem. And as long as those resources are there, we will be able to continue moving forward with that.
That's great, thanks. I'm going to just ask one more question, and I'm going to start with Angela, but if others want to give key examples in a couple of seconds each before we wrap up. Each of you talked about, and Angela, you, when you walked through the 5 pillars, talked about some of the successes happening. I think it's important for us to look ahead at what's coming down the pike, but also to talk about those success stories. So I'm wondering if you can give us what you think is sort of the most important success of DMI so far in Utah.
Sure. So there are several examples, but I'll just give one key one from COVID that was super important. So we have electronic case reporting, or ECR, set up with our major healthcare systems, so covering about 80% of our population. And the ELR feed dropped in the middle of COVID, meaning we weren't getting positive lab results from COVID via electronic laboratory reporting. But because we had electronic case reporting set up, it allowed us to still get those positives in a very timely manner to be able to ensure we were contacting them and implementing quarantine and isolation procedures to prevent the further spread of COVID. And so it's really important to understand that throughout all of this, we all know that duplication and redundant processes are super important when relying on technology. And ECR is definitely a key example of that. It's another tool with ELR and all these other things. It doesn't replace what we already have, but it allows us to be more efficient and stable.
Thanks, Angela. Megan, do you have a good example on the lab side from your sort of favorite success stories?
I think given the fact that we had some eTour capability in place prior to the pandemic, because it's something that we've always wanted. We were when we got test requests from our already set up submitters, I think all of our staff breathed a sigh of relief. What was really problematic was all the new submitters that we were getting specimens from. We were having COVID outbreaks, and those all had to be manually entered. And so we've been able to use that to justify funding for setting up a lab web portal. We're not quite there yet. Just my LIMS administrator starts on Monday, so hopefully we'll be able to get these in place. But I think just having at least a backbone of eTour in place, really helped a lot with our response.
Thanks. Shauna, any last comments from you on sort of how else CDC and the federal government might support vital records?
Well, thanks, Erin. I will say that, I mentioned in the beginning of my remarks that we've worked so closely with Dan and all of our partners at CDC over the last 20 years to transform vital records from that paper process to an electronic process. And I think maybe the best way to leave it today is to say that I don't think we can wait another 20 years to transform again. We just can't. So it's just so important for all of us to be on the same page and be able to support the people and the structures in our states, territories, our tribal communities to do the work that they need to do to protect all of us when the next disaster, pandemic, whatever happens.
Thanks, Shauna. And Valerie, the last word is yours in just a couple of seconds. You talked about some really big estimates and maybe some numbers that might shock people listening to us today. But when you really break it down, it's not that much money across all of the needs from IT infrastructure. Can you just give us a quick sense sort of how you and your colleagues at HIMSS are talking about this from a messaging perspective, and how should we be talking about this to really ensure that these big estimates are making sense to folks and hitting home?
Certainly, we're definitely looking at this through, obviously having a really sort of core messaging for the healthcare community, which is really to align our efforts. And that's certainly something that the pandemic has taught us, is that healthcare and public health need each other. We rely on each other. And with across a 10-year level of investment working together, we can realize a true modern 21st century, robust, bidirectional health data system, that works towards all of our interests, and that also galvanizes on the promise of digitization, standardization, in support of those state, local, and tribal levels. Definitely want to give a big shout out to those working in more rural settings or low resource settings across the US. We often do not think about their level of engagement, but that is definitely where we have really sort of honed in. The bulk of the resources that we have estimated in our funding report are really driven toward the state, local, tribal, and territorial levels, because they really are playing catch up. We call it synonymous to being that little red caboose hanging on the back of a bullet train. So we're really pulling forward to ensure that they are supported and they are able to connect and they are able to leverage and realize the promise of the CDC DMI at the state and local level.
Thanks, Valerie. And thanks everyone for taking the time to join us today. I'm going to wrap up the formal part of our webinar here. And just a couple of quick notes for those of you who are able to hang on. For those of you who are joining us from the Hill, I wanted to make you aware of a House Dear Colleague letter being led by Congressman Peters in support of $250 million for DMI and $50 million for the Center for Forecasting and Outbreak Analytics. You can contact Dylan Cook if you're interested in joining. If you're joining us from the public health community, there's a link in the chat. We have a sign-on letter with over 100 groups on board in support of those same numbers, and we would encourage you to join the letter if you can. And finally, if you are able to, we encourage you to join us next week for part 2 of this series, Better Data, Better Analytics, and Better Response, to learn more about the CDC's new Center for Forecasting and Outbreak Analytics. And there's a link in the chat to register and for more information on that event next week. So thank you again for joining. If you can, please stick around for our informal dialogue with a few of our speakers. I know we can't be in person today, which is a bummer, but we're going to give it our best shot in this informal session afterwards. So if you want to stay on the line, please just accept the panelist invite when it pops up on your screen. And we look forward to seeing you there. We will not be recording the informal session, so feel free to join and have your questions ready. We'll use a raise hand function when we get there. So thanks again to all of our speakers. Thanks for joining us today.